a 35-year-old male patient presented to you with left groin mass and a single palpable testis. On ultrasound scan, the groin mass was an undescended testis and is very solid and has a cystic component. Well, what are the types of testicular tumor that you know?
So we have germ cell tumors. So germ cell tumors and non-germ cell tumors. So germ cell can be divided into seminomatous, non-seminomatous. So on seminomatous, we have seminoma and spermatocytic seminoma. And on non-seminomatous, we have choriocarcinoma, yolk sac, and embryonal. We also have teratoma and some sex cord stromal. On sex cord stromal, we have Leydig and Sertoli cell.
Yeah, that's right. So you have germ cell tumor, such as seminoma, embryonal carcinoma, yolk sac, teratoma, choriocarcinoma. And on the stromal cell side, you also have Leydig cell tumor, Sertoli, granulosa, and multiple other things. You don't have to give the whole examples, just mention one or two, and that should be absolutely fine. What are the predisposing factors for testicular carcinoma or testicular cancer?
We can have family history. We can have cryptorchidism. We can also have low birth weight or prematurity, and we can also have maybe history of Down syndrome.
Okay, how would you define cryptorchidism?
This is a failure. It could be complete or partial of descent of intra-abdominal testis into the scrotum.
Okay. Yeah, so it's complete or partial failure of the intra-abdominal testis to descend into the scrotum. Well done. How does undescended testis contribute to the risk of testicular cancer?
It is about 3 times risk of developing to testicular cancer, because
Yeah.
there will be
What will be your management in this patient? This patient is coming to you with undescended testis at the age of 35, and it has solid and cystic component. What's your management?
So I will escalate this management with my consultant, and we discuss this in multidisciplinary team. Would want to do staging investigations. So we do staging CT, abdomen, chest, and pelvis, and we might want to do chemotherapy or orchidectomy as well.
All right, but you want to go a little bit earlier than this. So you're currently with the patient, reviewing them. So you want to say, I would like to take history. I would like to examine the patient, look into the testes, and feel the solid and cystic component as well. I'd like to examine the lymph nodes. And after doing all of this, you want to do the triple assessment. So history, examination, and some investigations as well. Investigations that you're going to offer, this includes some basic bloods and some tumor markers, and I want to mention those specifically as well, like lactate dehydrogenase, like lactate dehydrogenase, and also the beta HCZ as well, and alpha fetoprotein. And you want to offer some imaging, including CT cap and ultrasound on the pelvis, and ultrasound on the scrotum as well, to further assess the mass that you have there. And uh, after imaging, you can do some biopsies, and this could be either doing complete orchidectomy and sending it for biopsy, or doing a fine needle aspiration cytology from the cystic component, right? So you can, and after doing all of this, yes, you can escalate to your consultant, you can discuss in the MDT, but you're expected to know all of this without having to discuss with the consultant, all right?
Okay. Yes.
Okay. Fine. So triple assessment is your key word here. We've done all of that. We've sent a pathology report, and it shows teratoma with some positive margins and some lymphovascular invasion, and it's T4, NX, and MX. We don't know the N and M yet. Okay. Can you
Yes.
discuss the pathology report with family in 3 simple words or 3 simple lines?
All right, so I'll tell the family that this is a cancer, and it is spread, and it is incomplete resection at first.
Okay, that's well done. That's very well done. Very, very specific, right? So you want to say, one, this is cancer in the testis. Two, it has positive margin. That means it's incomplete resection, and it has a spread to different areas of the body as well. Okay, where does teratoma spread first?
First, it involves the para-aortic lymph nodes and then to the lungs.
Okay, so it goes to the para-aortic lymph nodes first, very usually. And where does it spread next? You said lung next, right?
Lungs, yes.
It can actually go to the local regional area, and by that means the local area, the groin basically on both sides, all right? The serological markers that you can do, I think I've mentioned the three of them, which is, can you mention them again?
Okay, a alpha fetoprotein, lactate dehydrogenase, and beta HCG.
Well done. All right. So those three are quite important for specifically testicular cancer. They are important in other cancers as well, but more important in testicular cancer. Post-operative, the patient had hematoma. Can you mention what are the stages of a hematoma resolution?
We have lysis of the clot and growth of fibroblasts. I know there are three stages, but I don't remember the last one.
That's very, very fair. So initially, lysis of the macrophages, and then you have growth of the fibroblast into the hematoma. And the third is actually just resolution of the hematoma. All right. After the growth of fibroblast, the hematoma will start to completely resolve. After a few months, the patient had a small pneumothorax. What could be your explanation to that?
This is metastasis to the lungs.
Okay. Yeah, lung mets very usually. How would you define metastasis then?
This is a manifestation of symptoms at a site which is different from the original site of the tumor.
Okay, but I think there is a better definition. It's the ability of the primary tumor cells to survive and live in areas away from the primary site. Okay, so it's the
Yes.
ability of the cells of the primary tumor to survive away from the primary tumor. Okay, all right. This patient had shortness of breath. Okay, so 1 year later came back with para-aortic lymph node compressing on the renal artery and vein, and shortness of breath and PA as well. Can you explain to me why did this patient have a PE?
From the Vicos tried, this patient could have stasis, or cancer is a hypercoagulable state.
Is there anything else?
And endothelial injuries from the surgery, from the resection which was done at first.
Is there anything else? So yeah, I mean, the patient has a tumor in the groin. If this tumor is spread to any of the lymph nodes, causing any pressure on the draining veins of the lower limb, they can have venous stasis as well. So they have active cancer, there's this hypercoagulable state, and also venous stasis, according to Vergau's triad, of course. What is choriocarcinoma?
This is a malignant form of cancer which consists of cell types which are syncytiotrophoblasts and cytotrophoblasts.
Yeah. So it's a highly malignant testicular tumor, cyto and syncytial trophoblast. Okay, what are the tumor markers of choriocarcinoma?
We have beta HCG.
Is there anything else or no?
This one is the specific one.
Very specific beta HCG, that's right. What is the common testicular tumor in men older than 60?
Lymphoma.
Testicular lymphoma. What is the histopathology showed in this patient? Papillary thyroid tissue and GIT adenocarcinoma. Can you explain to me why?
This is a teratoma. It is three germ cells: the meso, the endo, and the ectoderm.
Amazing. Well done. I think you've done very well on this scenario. Very specific, very short answers, which I really like in the exam. And this is how it should be in the exam. Very specific and short, right? As short as you can. Okay. I mean, short but accurate. That's the more important bit.